Chapter 9, pain. What is the accepted definition of pain for nursing?
Anything the patients tell you.
Okay, all right. Then you paraphrased, yeah, but this is the complete definition. So the nursing profession accepts this description or this definition of pain. This is from Margot McCaffrey, all the way from 1968. So it's highly subjective, correct? There's no objective portion of this definition. So it's based solely on the patient's self-report. Okay, so the patient's self-report is the standard, also the most reliable indicator of pain. Reason for this is people react to pain differently, meaning not all people grimace, not all people will have any vital signs changes, especially with chronic or cancer pain. People adapt and their bodies no longer respond the same way to pain as other people would. There are also cultural differences. Pain experiences are unique to each person, so there's really no one way to express pain. All right, so it's highly subjective, highly unique to the person experiencing the pain. So don't expect your patient to prove to you that they have pain, because that will be disastrous if every patient under your care has to present proof that they are in pain, for which again there's none. There's no physical proof of pain. It's highly subjective. If you have any preconceived prior experiences that may affect how you treat your patients in pain, I'm not saying to change it, but I'm just saying this is how we treat pain in the nursing profession. So if you have any if you have any biases, any prejudice from your previous experiences from people, if you have any prior clinical experience, it's important to acknowledge your biases. That way, if you're aware of them, then you can better take care of your patient. So these are the effects of pain. It's not just physical, so it can affect psychologically the entire body. So it's especially if it's unrelieved pain, this can affect all body systems. Let's proceed with types and categories of pain. So let's start with the type. By type, we can differentiate acute from chronic pain. Chronic is also called persistent. Acute pain usually involves these types of causes. Okay, these are acute type, meaning abrupt onset. Okay, acute onset, but they may not always be with onset, because although they occur in relatively short period of time, however, they can be prolonged unless the patient receives intervention, whether that's pharmacologic or non-pharmacologic. With the chronic types, though, are also called persistent. It's never resolved, meaning the patient will have varying degrees of pain over time, over the months, over years, and the level of relief that they seek may be unrealistic, meaning some patients with chronic pain will have a goal of 0, which is, as mentioned, may be impossible to achieve. So maybe the patient will have to settle with a different level of relief so that they have a more realistic goal. Cancer pain used to be under chronic, but the American Cancer Society put cancer pain as separate. Okay, There's also something we call breakthrough pain. Breakthrough, as defined here, is commonly occurring in between chronic pain episodes. Meaning, let's say if I have cancer, I have a big tumor in my abdomen or in my skull, for instance, in the brain. I'm always in pain. This is my usual pain. However, there will be periods throughout the day wherein the pain is extra strong. It's not the same pattern as the usual pain I experience. So that is called breakthrough pain. Breakthrough pain, it is treated differently, meaning you cannot treat breakthrough pain, although it occurs with chronic pain, you cannot treat it with the same pharmacologic interventions for chronic pain. This has to be treated separately. So we will approach pain, and when we get to the interventions, both pharmacologic and non-pharmacologic, that it will involve a multimodal approach. So patients, especially with chronic or persistent pain or with cancer pain, will be treated with different types of opioids or non-opioids as well, usually a combination. By pathology, so this is now under the categories of pain. Pain can be either nociceptive or this is also known as somatic pain. And then we have neuropathic pain. Nociceptive pain results from a physical or physiologic system, meaning the production of prostaglandins and other pain neurotransmitters. However, in neuropathic pain is abnormal. Okay, so here in normal nociception, they follow the normal process of pain, mechanism of pain from the release of pain signals from pain neurotransmitters to the transmission via your spinal cord, and then it is evaluated by the brain, and then the brain modulates, and then there's a response. In neuropathic pain, this is a type of abnormal processing, meaning there is no physical reason for the pain to exist, but then yet it exists. All right. So usual examples when we say nociceptive pain are the same as those from acute and chronic pain. However, in neuropathic, examples here are phantom limb pain. You may have heard of that term, wherein the patient lost his left leg, for instance, but then they feel the left leg is painful. Okay, so it's not making any sense, right? I mean, the left leg is missing, but then they still feel the pain in the left leg. Other types of neuropathic pain are those from diabetes. Patients with diabetes have nerve damage in one or both legs and feet, and then they feel pain there. But then when you examine the foot, there is no physical injury whatsoever there. So that's another example of neuropathic pain. Another is the post-herpetic pain. That's what we call pain from shingles. If you've ever heard of shingles, it is a painful rash caused by the chickenpox virus or varicella virus, and that's another type of neuropathic pain. These are the harmful effects. So as you can see, it's systemic. I'm not going to test this, but just know that pain affects the entire body systems, most especially quality of life. Okay, so patients will have serious unrelieved pain specifically will have serious effects on the patient's overall well-being. And here are examples of nociceptive pain. So this is the normal process I mentioned earlier. So pain process starts from transduction to transmission to perception to modulation. Again, this part is not testable. Let me just explain and give examples of this and how we approach pain management. So since this is the 4 processes by which pain is produced, transmitted, and then modulated, we can interrupt the pain process at different points of the pain process. For instance, if we, let's say, transduction is the production of the prostaglandins and other neurotransmitters for pain. So if we give drugs that will inhibit prostaglandin, for instance, an example is ibuprofen. So ibuprofen, the action is to inhibit prostaglandin synthesis. So therefore, it stops pain at the transduction phase of the pain process. So that's one example. Another example is the transmission. We can interrupt the pain perception, the pain process through transmission. Example would be a nerve block, or who've had epidurals here? Any mommies that had an epidural during labor or delivery? Okay, so a few of you have had that. So that's an example of interrupting the transmission, meaning the pain is there. It's not, the signals are just not transmitted because you blocked it, okay, with an epidural, for instance, or any spinal blocks, right? For perception, this is where opioids come in. So we give you morphine, we give you hydromorphone or oxycodone. The pain is still there. They are transmitted, but what we're altering is the perception. So we're giving you opium products to alter your perception of pain, meaning it messes with the pain receptors in your brain. So although the pain exists, however, your sensation of it or your perception, how your brain interprets it, is interrupted because we gave you opioids, which alters your perception of the pain. And then finally, modulation, we can use that with medications as well, or with a combination. Usually the example here is the gate control theory. For instance, have you ever hit your shin on something? That's probably one of the most painful experiences, right? So you hit your shin against a low table, for instance.
No, stepping on a Lego is hurtful.
What was that, John?
Stepping on a Lego.
Oh yeah, stepping on a Lego. So what do you do after you do that? What do you do to your foot or to your shin when you hit it?
You rub it. Well, I rub it.
Okay, so that's what we call modulation. So that is based on the gate control theory, meaning the gate control theory states that if you close the gate toward the brain perception, so an example is that they believe that painful, unpleasant sensations, whether you taste something bitter or you feel pain or sadness, for instance, all the unpleasant human sensations travel through small nerve fibers, and all other pleasant sensations, including, let's say, sex or listening to music, the joy you feel when you're watching a concert, a nice movie, or a comedy, for instance, you're laughing, or eating ice cream or any other favorite food. These are traveling through large nerve fibers. So when you rub your shin or your foot after hurting it, so you are stimulating large nerve fibers, and they believe that when you stimulate the large nerve fibers, then they cancel out the transmissions via the small nerve fibers, because larger nerve fibers can be transmitted first over the smaller ones. Anyway, these are pain management theories, but they make sense. Okay. Again, I'm not testing table 9-2.
Hello, thanks for calling DND. To continue in English, press 1.
Okay. In Spanish, press 2. So that's all about, so here's the examples. I already summarized them earlier. So I gave examples of transduction, and here's the gate control theory. Here's the how you interrupt transmission, and altering perception using opioids. Okay. Again, they're not testable. Okay, I'm just trying to explain why we use different approaches to pain and what you can use besides medications. Okay, so there are non-pharmacologic ways to manage pain. And we already talked about examples of neuropathic pain. All right, let's go straight to the assessment. All right, so we have different types of patients. Are all patients cognitively there? Are all patients awake and aware?
No.
Okay, so for those patients that are not alert, awake, I'm talking about sedated patients, unconscious patients, patients with autism, patients with mental retardation, patients who are developmentally challenged, patients who have dementia. So there's no limit, all right? So not all patients are awake and alert. So therefore, can we use only one pain assessment tool? Meaning some patients cannot report pain, right? I mean, I gave a few examples of why they will be unable to report pain because, again, a reminder, pain is subjective. So the patient's self-report is the most reliable indicator of pain. So for those patients other than alert and awake, can you use the numeric pain scale to assess their pain?
Yes.
The numeric pain scale?
No, I
No.
don't think you can.
No,
No,
you can't.
no,
You can
because
only
you
use
can't
it for those
express
that
it.
are awake that can speak, but the ones that are not, you cannot use it for them.
All right, so we'll discuss a few alternative pain assessment tools for all other patients that are not awake and alert. All right, let's discuss 9-1 first. So this is for those who have preconceived biases or prejudice against people. Who among you have heard or encountered patients who were labeled quote unquote drug seekers?
Drug seekers?
Yes, they are people who frequent emergency rooms, complaining of pain, and then doctors would order CAT scans, MRI. They can't see
Oh,
any signs or source of the pain, but then they frequently visit multiple ERs, complaining about the same thing.
Yes, they are the crackheads
Yeah.
and the drug addicts.
Okay,
or they got
very good
opioids. It's
that
mostly
you
opioids.
use those terms. Okay, so let's discuss that using chart 9-1. Okay. First of all, you heard Miss Kalu say, besides drug addicts, what else? What other terms did you use, Miss Kalu?
She said the crackheads.
I said the crackheads.
Okay, all right. So
I've been seeing a lot of them.
okay, let's look at bullet number 1.
Acknowledge that everyone is entitled to a personal opinion, but personal opinion does not form the basis for professional practice.
Okay, so Miss Kalu, Yes, you are entitled to your personal opinion when you said those comments or those terms earlier. But what does the rest of the sentence say?
I have to read it
Yes.
to
Start with-
clarify that the sensation of the pain is subjective and cannot be proved or disapproved.
No. The one I highlighted, the second part of that statement, this one.
Okay, but personal opinion does not form the basis for professional practice.
Okay, are we clear on this, everybody? Not just Ms. Kalu, okay?
Yes.
Okay with the first statement?
Yeah.
Yes, you can have all the comments you want, whatever you think about that patient under your care, but what does it say? Your opinion will not form the basis for practice. Are we clear on this one?
Yes.
All right, so let's look at number 2. So, Ms. Kalu, you already started, so can you read it again, please?
Clarify that the sensation of the pain is subjective and cannot be proved or disapproved.
Or disproved.
Yeah, disproved, yeah.
Okay, so everybody accept this? You have no choice anyway. So this is for
Yes.
practice. We have to, right? So it's purely subjective. Do not ever ask the patient for proof that they are in pain. You cannot prove it. You cannot disprove it. What is the only reliable source of information?
The patient.
The patient's self-report. That's it, period. No buts, no ifs. Now, if you have ever, because I'm sure in reality, you will encounter people that you find so hard to believe that are in pain. I mean, here they are laughing, talking on the phone, but they call you and say, hey, I need something for pain. And then you do your assessment. Okay, where is it? Describe the pain. Where's the location? What started it? You do a complete PQRST, including the severity. But then they are laughing and smiling. So if you're really doubting that they are in pain, all you can do is document it. But you cannot refuse the intervention. You cannot ask them to prove or disprove the presence of pain. All right? Is everybody clear on that? You can just document. You can just document.
I'm clear.
Patient, the complaint of pain, and then this is the description, this is the level or intensity, and then you document. Patient was on the phone, seen smiling and laughing, no grimacing. That's all you can do, is to document the behavior. Right?
Professor, can I ask a question, please?
Sure.
So, what if there's a patient that have a history of hopping from different hospital to hospital, asking for a precise medication for pain, and it's on record that they ask for this particular medication. They come into ERs and ask for these particular medications for pain.
What is your? I didn't see a question. You said just what if? I didn't see a question mark. What is the question?
What exactly would you consider that? Because I understand where you're coming from when you make that statement, but they do have patients that jump from hospital to hospital, ERs to ERs, and request, like they come in there and request for a precise medication for their pain.
Okay.
And
yeah, go ahead.
no, I'm just wondering what exactly would you say towards that?
Okay, so we are in the nursing profession, correct?
Mm-hmm.
So this is all nursing. I don't want to go into what the doctor will do. That's it, period. Okay, I'm not a physician, so the physician, that's his call. All right, but as nurses, we're bound by these strategies and these principles because that's what we accept as the definition of pain.
Okay.
All right, and then here, so For everybody who still have those preconceived notions, here, why is it so difficult to believe that this patient hurts? Okay, so just ask that and then move on. Go with your job. All right, so your job is to assess the patient's pain and to treat the pain because it's subjective. It's subjective, cannot be proved or disproved. All right. I want to get this out of the way before we move on. Is everybody okay with this? I mean, understand. I know
Yes,
some of
Professor.
you are not okay with it, but this is what you're going into. If you can't accept this, then go somewhere where you don't have to deal with people. All right, maybe you'll still be a nurse, but maybe you work in the dungeon because you can do that. No, I mean, what I meant by that is you work with computers. Okay, so there's let's say you're on care planning. All right, so you're a insurance nurse. Okay, or let's say you're a software developer. Right, there are nurses like that. So you help build or maintain or improve systems, engineering. Okay, so let's say you're building programs. Okay, so they need nurses for that because they need your clinical expertise. Okay, something like along those lines, where you don't have to deal with people, or with things that talk. All right. So here's another one. Someone wanna read this again?
I can read.
Thank you.
Quality and safety nursing alert. Although accepting and responding to the report of pain may result in administering analgesic agent to an occasional patient who does not have pain, doing so helps to ensure that everyone who does have pain receives appropriate care. Healthcare professionals do not have the right to deprive any patient of appropriate assessment and treatment simply because they believe a patient is not being truthful. Pain is an extremely personal experience manifested uniquely by each person. It is important to carefully assess and reassess pain when administering analgesic medications.
Analgesic medication.
Sorry, analgesic medication.
Analgesic.
Analgesic.
Oh, very good.
Music.
All right. So again, I'll put this to bed now. No more arguing. If again you have problems with accepting this, then again I recommend you work in the dungeon. Okay, so avoid things that talk. So let's proceed with the assessment now. So it has to be complete. Don't just say, "Oh, okay, you have pain. Okay, then you go grab the MAR and then check what's ordered." Okay, so you have to do your job, do your assessment first. So starting with the location, intensity. How would you ask location? So here's a suggestion. Okay, so point out where is it, and then intensity. There are many tools that we let's look at chart 9-2 for the different tools. Intensity is only one part of it. So you just don't ask for, okay, how bad is it 0 to 10? That's not the only pain assessment. You still have to ask for about the location, description of the pain, meaning quality. Okay, so here are the pain rating scale. This is describing the verbal or numeric pain scale, but there are others besides the numeric rating. So we've got the Baker's, one Baker faces. So this corresponds with a picture, correct? From a smiley face to a frowning face. This is combined with Wong-Baker and faces is very similar. There's also the verbal descriptor. No pictures, but they just have these terms and then it's still equating to a specific number. Then we've got the visual analog scale, same thing, similar to VDS. And we also have, let's finish the others. We've got the here is our other tools we can use. For infants, for instance, since they are non-verbal, we can use FLAC. This stands for facial expression, leg movement, activity, crying, and consolability. So the tool will have corresponding numbers based on each of these behaviors, from the face all the way to consolability. Based on this, they made one for dementia patients. Acronym is PAINAD, so that's Pain Assessment in Advanced Dementia. So it's similar to FLAC, but not entirely. But do not use FLAC for a dementia patient because they're not infants. And then at the same time, don't also use PAINAD for an infant. Okay, so you should use the appropriate tool for the appropriate patient. This one is for our sedated or unconscious patients in critical care. So it's also based on behavior, from breathing, similar to PAINAD. These two are very similar. But again, because these patients are nonverbal, not awake because of sedation, or maybe they're in a coma, then we use these tools instead. All based on patient behaviors and breathing effort. For reassessing pain, this is always part of the charting. Today, no matter what type of EHR you're using, whether it's Epic, whether it's Allscripts or McKesson, Cerner, right? So whatever computer program your hospital uses, this is now standard. Every time you assess the patient and there's a number other than 0, it will ask you to reassess based on your intervention. So if your intervention is non-pharmacologic, it will still ask you at least an hour after your initial assessment. It will pop up on your work list to reassess pain, and it will not disappear from your work list on the computer unless you address it. Okay, you have to put a number there. What happened after an hour? And then it will also ask you for what intervention did you use, whether it's pharmacologic or non-pharmacologic. The rule is, if it's oral medication, you have to assess within an hour. If it's parenteral, meaning IV, IM, sub-Q, then it's 30 minutes after the initial assessment. Feel free to interrupt whenever you have a question, right? If you're wondering about what the items are that's scored on PAINAD, so let's look at the PAINAD tool. So as I said, it's all based on behavior. So here's a standard PAINAD tool. So it starts with breathing right here. Can you see this screen on the PAINAD scale?
Yeah.
Okay. So under breathing is normal, that's a 0, and then occasional labored breathing, 1, and then 2 for noisy labored breathing. And then it goes on to vocalization, facial expression, body language, and consolability. So the last three I showed you, the FLAC, the PAINAD, and the CPOT, are all behavior-based. Okay, they have similarities here, but FLAC does not have any breathing. Okay, so FLAC only had the facial expression and then leg activity, typical what baby behaviors usually are. Any question on the tool? Okay, so we can assess every patient. There's a tool for every patient. All right, let's go to pain management now. As I mentioned, we will approach this in a multimodal way. So we're not just using one method. I encourage you to use all of them, if possible. Sometimes we'll only remember non-pharmacologic if we run out of it. So there'll be times wherein you'll encounter patients with really intractable pain. Very poorly controlled pain makes you doubt why you became a nurse, because throughout that shift that you have to deal with that patient, and it's only the first hour of the shift. You still have 11 to go, dealing with the same patient. So makes you resourceful. Okay, so you have to be creative with how you approach it. So you can use, because again, at that point, you may run out of the pharmacologic interventions already. You call the physician refuses to add anymore. So now you're left with your wits, all right? So on how you will approach the pain. So most non-pharmacologic would be either the massage, for instance, music therapy. Not all patients will accept that, but the mere discussion of it actually is already part of distraction. So it takes the patient's mind off of it. So let's say the patient starts to argue with you, I want my pain medication instead, or whatever they're saying. So that's already a non-pharmacologic pain approach, if you think about it. Okay, so the mere fact that they're arguing, I wouldn't really call it arguing, or just let's call it discussion. So the fact that they're discussing it with you, that's already part of your pain management. Okay, at least that's how I looked at it. Okay, so let's start with pharmacologic first. Again, we use a multimodal analgesic approach. So use several types. This is usually a combination of opioids and non-opioids, depending on the patient's type of pain. Routes. We prefer the oral route as much as possible, unless the patient's NPO or the patient's unconscious, or there's a contraindication for the oral route. Most acute pain, especially if it's post-op, is managed with IV. But as the day progresses, let's say post-op day 1, 2, and 3, after surgery, then we try to wean the patient off the IV and start giving oral, because we have to prepare for discharge.
Good evening.
What did I say? Oh yeah, so we have to prepare the patient for discharge. So encourage them to switch to oral so that we can facilitate their transition from the parenteral route to the oral route. Later, we will discuss equinalgesia, because in order to maintain pain relief, you have the doctor has to know the equivalent dose for a drug when we switched from parenteral to oral route. Okay, we'll get to that. I think it's a table later. Topical is another option. We have, when it comes to topical, patches are released at a certain micrograms or milligrams per hour basis, unless the patient rubs or scratches the patch, then that will cause a sudden delivery of the medication. That is that's not really recommended. That's actually dangerous. As with any other topicals, what do we do before when giving them?
For tropical drug,
Yeah, anything topical, whether it's an ointment, a patch, cream. What's the rule?
you use a small
Never
amount first.
the same spot.
Well, we typically put it over the painful spot, unless it's a generalized pain. So let's say you're giving a fentanyl patch, then it doesn't have to be on the painful spot. Okay, you can put it in any part of the body because it's absorbed through the bloodstream and in the bloodstream through the skin anyway. But for others, let's say lidocaine, which rely more on local absorption, so that would be applied to the painful area. But what I was asking is, because these are absorbed through the skin, what is the nurse's
You gotta
responsibility?
sanitize.
What
You
should
gotta perform hand hygiene.
you
Yes,
wear?
Gloves.
Gloves.
Okay, so that's what I'm getting at. So make sure you wear gloves when administering these, all right? Because that you will absorb it as well if you touch it. All right, dosing regimen. This is now the frequency of the administration. So routes, again, we prefer the oral, if at all possible. If not, then we'll go through parenteral or topical routes. Regimen. So this is the schedule of how often you're administering the medications. It really depends on the type of pain and also the nature of the pain source. If the patient is, let's say, post-op, in that case, we expect the patient to have pain, correct? So to better manage the pain, they should be on a ATC or round-the-clock basis rather than a PRN, because we know they're going to be in pain. They just had surgery. They have injury to muscles, tissues, or even bone. So therefore, since we expect the pain to persist over a certain period of time, then they should be given the medication on a regular basis. But we still have the PRN available, of course. In case you're wondering what PRN stands for, this is actually, I think it's Latin. It says pro re nata, which is translated through as the circumstance arises, something like that. I think that's what it means, as the circumstance arise. So same meaning as needed. So they would benefit, post-op patients would, and those people with those types, so not only surgical but also pre-surgical. Say you have appendicitis, that kind of pain, or let's say you had a heart attack, for instance. Okay, so those patients we also put on a round-the-clock basis as far as morphine goes. PRN dosing is more for intermittent pain. And remember the breakthrough pain earlier? So we also use PRN dosing for breakthrough pain. Okay. Have you discussed PCA before? Maybe fundamentals of nursing?
Yeah, the pump, right?
Yeah.
Okay. Okay, the most common type of PCA is IV, and we have the pump for that. But please be aware that we have other types of PCA. We do have oral PCA, wherein the machine dispenses a tablet to the patient. So just make sure you're aware of other routes. Okay, so here it's mentioned there are other routes, multiple routes for giving PCA. So there's oral, there's IV, which is the most common. There's also subQ, epidural even, and even perineural. Okay, so there are different ways to deliver PCA. The concept though is the same. So what is the whole idea about PCA? It allows the patient to treat their pain by self-administering the analgesic agents. We usually use opioids, but they can use non-opioids, although very extremely rare. So PCA, majority of the examples are opioids. Okay, we use opioids with PCA. But this is the whole point. Self-administering the analgesic. So therefore, since it's self-administering, what do you think are the two requirements for someone to receive PCA? What must the patient be able to do? Like if I qualify for PCA before a doctor prescribes it, what must I meet? I need to meet two things.
To be able to push it yourself?
Not entirely. Because that means you need a finger, right? That's not really a requirement. Because we can't activate the device by other ways. We don't have to press a button.
Well, you have to be the one to administer it.
Correct. So what
Someone else cannot administer it for you.
I know.
That's what I meant.
Yeah. So therefore, what's a requirement?
They need to understand the
Patient
medication.
Yeah, okay. Very good. So the patient must be cognitively able to use the device. All right. So my mind must be able to use the device. Okay. Again, I don't have to physically activate it. Meaning, if I'm a paraplegic, I'm paralyzed from the neck down. Can I use a PCA?
Yeah.
Yes, I am cognitively aware. I know how to use it. So I can receive a PCA. Activating a button is not really the only option. We have other ways to activate it. So these are provided by the Americans with Disabilities. So if I'm paraplegic, a quadriplegic, am I a disabled person?
Yes.
Yeah, there's no one, more disabled than that, right? So the law provides that I should be able to activate a PCA, okay, in my condition. So for those people, the companies came up with straws, okay, so blow straws. So what they can do is just simply, they can move their mouth, right? So they can just simply blow into a specific straw, and that will be attached to the machine, and we will activate the PCA. Okay, same thing. We also have those for call bells. All right, so we can attach those. I don't really know what they're called, but that's one way for them to be able to use a PCA or even a call bell. All right, next is let's look at the settings. Okay, so PCA is, like I said, majority are using opioids. So is there a danger of overdosing?
Yeah.
Okay, yes. So they can overdose. So therefore, most facilities require that every patient on a PCA is connected to a pulse ox machine. So we monitor their oxygen saturation continuously while they're on PCA. Because the earliest manifestation of opioid overdose is respiratory depression. So that's the reason for the continuous pulse ox. Somebody had a question? Oh, Dr. Masi, Mr. Ari.
Hi.
Hi. Yeah, we're done with the... All right. Let's look at the settings. There are 4 settings on a PCA. Because again of the danger of overdosing, the patient will be on a pulse ox, right? Continuously. Now, the order may or may not include a basal rate. Basal rate is not PCA rate. When we say PCA, that's the patient's administration, meaning the patient presses the button and they get the dose. A basal rate is a continuous infusion of the same drug in the PCA pump, meaning whether or not they press the button, the pump delivers a certain dose every hour. Okay, that's what we call a basal rate. Now, this is not usual. Not all patients will receive a basal rate. Okay, so stated here, basal rate is usually given to opioid tolerant patients. What do we mean by opioid tolerance?
Like addicts, like they just, it doesn't have no.
Yeah, maybe. Okay, yeah, they would qualify for that, right? But not just the addicts, though. I mean, people who are used to, that's what we really mean.
People who
Are-
pain medications doesn't do much for them. It doesn't help them.
Not really. When we say opioid tolerant, meaning, let's say, you know, with other terms, if are you tolerant with noisy people? That's what it means. Okay? So meaning these are people who are used to taking opioids. Let's put it that way. Does that make sense? Meaning they're not new kids on the block when it comes to opioids. They've taken opioids before. Okay, they know how it is. I mean, they take it on a regular basis. Let's put it that way. All right. So if a patient is opioid tolerant, meaning they're not likely to have an overdose because their body is so used to it. In fact, they're taking high doses of opioids on a regular basis. So those are the people who can receive a basal rate. Okay, because obviously will they require smaller or larger doses?
Larger.
Larger. So they can receive a basal rate. And look at the next statement. It is discouraged if a patient is opioid naive. Now, opioid naive patients are those who do not handle opioids very well. They may have received it in the past, but you know they have very poor tolerance to it. I mean, they easily, you know, pass out or you know get really groggy. Okay, their CNS the CNS depression is really bad when they take it. Okay, so those are what we call opioid naive patients, especially those who have never received an opioid before, right? So either they've had it but they can't tolerate it very well, or those who have never received opioids. Those are what we call opioid naive patients. Again, they are in danger of oversedation or overdosing. Again, earliest sign of overdosing is respiratory depression. So we put them on a pulse ox and we do not give them a basal rate. We only give them a PCA rate. Okay. So the next setting, so if they're opioid naive, you won't have a basal rate. The doctor would not check basal rate. So next setting is the PCA rate. The PCA rate is a certain amount of the drug that will be delivered every time they press a button. Okay, so they will receive the PCA dose or the PCA rate when they press the button. Okay, so that's the second setting. The third setting is it's not mentioned here, so I'll just continue. So the third setting is the 15-minute lockout. This is standard for all PCAs for safeguarding the patient again. We don't want a overdosing again. So every 15 minutes, even if the patient presses the button 1,000 times in that 15-minute period, they will only get one dose every 15 minutes. Does that make sense?
Yeah, Professor, it makes sense.
Okay, so that's a 15-minute lockout. The last setting is a 4-hour limit. This is again all set by the physician. So This is again to safeguard from overdosing. So every 4 hours, the patient can only receive a certain maximum dose. Okay, so again, let's review the settings. So they may or may not have a basal rate. Again, who gets the basal rate? Only people.
Opioids, patients who have opioid tolerant.
Okay, opioid tolerant, they get a basal rate. Opioid naive, will they get it?
No.
Okay, what's the second setting? The PCA rate. Okay,
Siri.
yeah, we give them a PCA rate. The doctor sets it. And then third is the 15-minute lockout, and then the 4-hour limit. All right. Let's look at a picture of a PCA pump so you have an idea. So it's a specific pump. It's not a regular IV pump. It has a way to lock it, usually made of either glass or plastic. This is the Alaris series. This is a very common pump. So let me explain what you're looking at. So this is the brain of the pump, meaning this is the drug library. This is not a pump. This is just the brain. Okay, so this contains the library. The actual pumps are these 4 attached to it. This particular model can accommodate multiple pumps, meaning you can attach multiple here. This can, whatever this pole can carry. Okay, so this IV pole, if it's big and sturdy, if it can carry 8, they'll put 8 here. All right. So each one will be labeled automatically. When you attach it, it will have a label. Okay, so if you attach this becomes A, this becomes B. So if you only have 3, then this will be C. Okay, so any additional pumps modules you attach becomes will be assigned a letter. All right, and you have the ability to control it from the brain. But these modules are the actual pumps. Okay. This is a bad example because this one doesn't have a PCA pump. All right.
D don't have the PCA pump?
No, none of these have, none of these are
okay.
PCAs. Yeah, none of them. Let's look for a better example. Okay, this one has it. All right. So this is an example of a PCA pump. Look at this module here. So this was Alaris pump. I don't know what that is, but this is the actual PCA pump. See how it has, this is a syringe. This is a 50 ml syringe, glass syringe, put inside behind this glass cover, and you see there's a lock here. Now, there's only one key on every nursing unit. So this is your floor. There's only one key for all the PCA pumps. They won't have multiple keys laying around. That key is kept in the medication dispensing cabinet. You may have heard of Pyxis or Omnicell. Okay, so these things are locked, okay, in a cabinet. The drugs are in a, think of it as a vending machine for medications. Okay, so it's locked. You can access it with your, you log in with your biometrics. Usually you put your fingerprint and it will open. So we need to track who got the key. And if you got the key, then you must return it. Okay, no other person can return the key so that we know who took it. Okay, so it's recorded who took the key. That means you got the key, then you must have opened a PCA pump. So if there's no PCA pump in use on your unit, then you have no business of retrieving that key. Okay, so we use the key to open this, and then we have access to the medication. Now, this is also kept in the same medication dispensing cabinet, and we need a witness, okay, to see was it full when it was installed. All right, and the nurse who witnessed must co-sign with you on your MAR. All right. And then whenever the patient is discharged or whenever we discontinue this, we also waste. I mean, you know the procedure for wasting, right? You need a second nurse to, again, co-sign that you wasted the medication. So this is one way for us to control narcotic access. So therefore, for you to commit a crime of stealing narcotics, you must have an accomplice, right? Because it takes two. It takes a witness. All right. So, and this is you see here on the screen. So there's the lockout interval here. This one happens to be a 10-minute lockout, and then there's the maximum. So this is what I mean by 4-hour maximum. So this one setting has none. Okay. PCA dose is 1 milligram, lockout 10 minutes. This one has a basal rate. See, it says continuous dose. So this one has a PCA dose and also a basal dose. All right. So that's how it will be set. It's really simple. All you do is it will walk you through, because you can't press confirm unless all of these are entered. So if there's no continuous rate, you just put 0. All right. Any question on the PCA pump?
No, Professor.
All righty. So that's how it works. PCA by proxy is prohibited. If a patient does that, well, proxy really that means it's either the nurse or a family member pressing the button for the patient. Well, we can't do that. If that is happening, if it's the nurse, then and the nurse is doing PCA by proxy, then that nurse will lose their job, probably their license. If it's a family member, we simply will just boot the family member, bar them from coming back to the hospital, right? I mean, the patient still needs the medication, so it's not the patient's fault. So we will just boot whoever's doing that, right? Any questions on PCA? All
No,
right.
Professor.
Yes. Okay. Analgesic medications. So these are non-opioids. Drugs under this are analgesics, which is the Tylenol. It's right here. So we got Tylenol, ibuprofen, ketorolac. Okay. So, but for opioids, obviously these are the opioids. There are many. The book just mentioned a few. For non-opioids, again, we'll use Tylenol and NSAIDs as an example. And then we have a third group, which are co-analgesics, also called adjuvants. Now, these drugs technically are not designed for pain relief, but they are used to augment pain relief. Examples are anticonvulsants. So we use this for neuropathic type of pain, or even antidepressants. Okay, so by composition, these chemicals aren't really designed to treat pain, but we use them for neuropathic pain. All right, if that makes sense. So they're called adjuvants or co-analgesics. Okay, so let's look at non-opioids first. So on the exam, on your blueprint, it says there you're going to be asked on the side effects right here for advantages, disadvantages, mechanism of action, and side effects for NSAIDs, opioids, and adjuvants. Okay.
Okay.
Okay, so let's start. So for non-opioids, these are the indications. Therefore, mild to moderate pain. And these are your examples. Okay, so for post-op, we actually give the Tylenol in IV form. Okay, there's an IV form of Tylenol, and it's given round the clock, either every 4 or every 6. but the patient definitely will receive no more than what? What's the maximum dose for Tylenol in a 24-hour period?
2,000 milligrams.
That's too small. It's a little higher than that.
4 grams.
4,000.
Okay, so 4 grams per day. Some drug books will say 3, but the widely accepted number is 4. Okay. Just make sure the patient is not getting more than 4. If the doctor does order more than 4, make sure they document it. Okay. Because they will order it, and then just make sure you put in the comment that clinician review, okay, or clinician approved, and then don't forget to document which physician did it. All right. You know, it's a cover your ass kind of thing. It can be combined with opioids for better pain relief, meaning you're using two drugs instead of one. As they say, 2 heads are better than 1. So same thing for medication. So if you combine oxycodone with Tylenol, if it's oxycodone, I think it's called Percocet, oxycodone and Tylenol. Or if it's hydrocodone and Tylenol, then that's Lortab or Norco. There are also non-opioid combinations like ibuprofen and oxycodone, and ibuprofen and hydrocodone. Okay, so different combinations. The beauty there is you're getting, you know, the benefit of 2 drugs that work in different ways to achieve the same goal. Of course, you're using 2 drugs, then most likely you'll have more side effects, of course. As already mentioned, so Tylenol, acetaminophen, is available IV. It also comes in a suppository and, of course, the tablets. Okay. If given by round-the-clocks, Tylenol IV comes in a glass vial. I think it's a 50. Yeah, it's a 50 ml glass vial. And it's infused over 15 minutes. So how many mLs per hour is that? If it's 50 mLs over 15 minutes, how many mLs per hour? That's 400 ml per hour, correct?
Yes.
Yeah.
Okay, all right. So, okay, so every 6 hours, again, maximum is 4 grams per day. Okay. We do have IV NSAIDs that's in the form of ketorolac, and in the form of topical, this is a topical NSAID, diclofenac. If you've heard of I think it's starts with a V, Vytorin, something like that. So that's diclofenac.
Yeah, it's Voltaren and
Oh, Voltaren. Okay, sorry, not
yeah,
Voltaren.
it comes in a patch, and it's wonderful, by the way.
Yeah.
I prescribe it all the time.
You use it too,
Yeah,
Mr.
no, I do. No, I prescribe it for patients. I may need it, but I'm having severe backache from a couple of days.
Yeah, I use it all the time on my knees. I got bad knees. All right, so let's go to side effects now. So Tylenol, number 1 side effect is hepatotoxicity. So what are signs of liver toxicity? What happens to your urine color?
Darker?
Dark,
Dark.
It turns dark, dark as in like Coca-Cola.
Coke.
Dark. Yeah, Coca-Cola dark.
Turner St. Johnson in the sclera of the eye.
Okay, so you'll have icteric sclera, or yellowing of your eyes, and also yellowing of the skin, all right? So this is what I mean earlier by, yes, it's 4 grams, but then here, some are calling for 3 grams, but until it disappears, so we'll stick with the 4 grams, all right? Other harm coming, oh, that's it for Tylenol. Let's go to NSAIDs. Now, NSAIDs can have a number of side effects, adverse effects, depending on the route, but people usually use oral, so that means it's systemic. There are 3 harms that can come that's been known to occur. So let's say a patient we just finished rheumatoid arthritis, correct? So if a patient has to be taking NSAIDs for a long time, they're at risk for, number 1, peptic ulcer disease. And peptic ulcer disease can lead to bleeding ulcers. So to protect them, because no other pain medications really work for those patients. So that's the best drug we can give them. So they'll be put on a PPI or a H2 receptor blocker, a ranitidine, for instance, just to keep the acid down. So this will help protect them from peptic ulcers. Another side effect besides GI is the kidney. Let's just go down the list. So next one is the risk for cardiovascular events, especially if the patient already has a history of heart disease. So typically we avoid NSAIDs with those type of patients. And lastly, so here's the ketorolac. This is the IV form of NSAIDs. Lastly, this can impair renal function. All these have to do with prostaglandin synthesis, which is what is inhibited by NSAIDs, and prostaglandins are potent microvascular vasodilators. So therefore, they damage the capillaries in the nephrons, and that's how they lead to chronic kidney disease. Okay, so those are the 3 major adverse effects of NSAIDs. So we've got peptic ulcers, cardiovascular events, and CKD. Any questions on NSAIDs? Oh, lastly, they also prolong bleeding time. So they're similar to aspirin. Okay, that's about it. For opioid,
What's COX-1?
These are the because there are COX-1 and COX-2. This stand for.
I saw COX-2, but
yeah, that's a acronym.
oh, it's down. Right there. GI project. Okay, thank you, Professor.
Okay. Opioids. So whichever opioid is prescribed, they all come from opium. They just have different strengths and formulations. So there are 2 groups. We've got MU agonists, and then we've got agonist-antagonist opioids. Examples for the first group are the following. So these are the true MU opioids used commonly in practice. So these are prescribed most commonly. And we've got these types which are not really that popular, but there are still around.
Professor, I can't see your screen sharing.
Is everybody the same?
No, I could see it.
Yeah, I'll probably
Look,
your screen.
we on 209 in the textbook.
Yeah, try refreshing your screen. Maybe it's just a lag with your, maybe something with your RAM, maybe, or your internet. Okay, so we discussed how opioids work earlier under the pain process. So this is under pain interpretation, right? If I'm not mistaken. So let's go to the side effects or adverse effects. There are 5 common adverse effects of opioids. They are constipation, nausea, vomiting, sedation, and respiratory depression. The 5th one is pruritus. What is pruritus? Itching.
Generalized itching.
It's itching.
Okay, that's itching. Okay, now you have to distinguish whether it's pruritus or whether it's an allergic reaction. Usually, if it's an allergic reaction, it involves other symptoms or signs rather than, in addition to the itching. So if it's just simply itching and it doesn't involve a rash, then that's most likely the pruritus. However, we talked about opioid naive and opioid tolerant patients earlier. Opioid tolerant patients are not likely to have nausea, sedation, or respiratory depression. However, opioid naive patients will have these. One thing that never goes away is constipation. What I'm trying to say is the longer the patient
Sorry,
takes,
Professor. Betina's waiting in the waiting room, she said.
so the more the patient, or the longer the patient takes the opioids and the more tolerant they become, then these go away. They no longer develop nausea, sedation, and respiratory depression. However, the the constipation will get worse. The constipation will never go away. It's there to stay. So what's part of your nursing care for patients on opioids?
Monitor BM or ask the patient if they have bowel movements
Is
and
that
give them Melalax.
okay? So is that the most effective way though, just monitoring, or are you going to anticipate it and put them on the bowel regimen?
Yeah.
Anticipate.
Okay, anticipate. It's gonna happen. Okay, it's not a matter of if. Okay, it will happen. It will bind their GI tract. They will develop constipation. And the longer it goes untreated, then it will just, cause other problems. There's also something called opioid-induced, OIC, opioid-induced constipation. And sometimes, Dr. Masi, what's that drug you guys prescribe for OIC?
You mean lenses?
No, I'm talking to Ari.
Yeah.
What's that drug again?
It's lenses, but I'm not very fond of it. It causes severe
Linzess, right?
electrolyte imbalance. Lenses.
Oh yeah, that's the one also known to cause bowel ischemia, right?
Right.
Oh, okay, yeah. Thank you. Let's talk about withdrawal. Now, withdrawal results from physical dependence. And the longer you take something, and of course, opioids feel good, right? So our body likes it. And then sudden withdrawal, sudden cessation of opioids, instead of weaning it off slowly, meaning tapering off the opioid, this usually happens when a patient is discharged, for instance. So let's say someone underwent some major surgery, let's say aneurysm repair. So let's say they had an abdominal aortic aneurysm, and then it was repaired. Those incisions are pretty large. So we keep them on opioids around the clock to keep them comfortable. and to encourage ambulation as well. So they don't, they're not bedbound. Now, because the patient was never in pain while they were in the hospital because we kept them on opioids, sometimes they don't understand why they have to take the opioids in oral form at discharge. So some of them do not bother to fill the prescription. We give them the opioid prescription, but then they say, "Oh, I'm not in pain and I don't want to get, hooked on these things." So they don't fill it. So as a result, was it a tapering of the opioid or was it a sudden cessation?
Pardon?
It was a sudden
Tapering? Oh.
No, I mean, what they did, was it a sudden cessation or did they taper?
Sudden.
Sudden.
Okay, so that bad decision will lead to withdrawal symptoms characterized by the following. So is this a good select all that apply question?
You said if somebody could read that for you.
I don't understand your question.
No, Professor, it's not a good select all that apply.
Okay.
No.
Well, I wasn't asking.
Oh.
All right. So all patients on opioids must make sure you have the antidote ready. So naloxone, you should be aware they come in different forms now, not just IV. We've got pill, we have the nasal spray as well. Okay. And this is made available now to the general public since the opioid pandemic. Let's talk about titration. What does titration mean?
To start that somebody start to be put back on something. Like if a patient was taking like clozapine and they stopped taking the clozapine, they were like taking 150, they're gonna start them back on like a lower dose or something like that.
Kinda, but
And the frequency.
the simpler term really for titration is adjusting. Okay, so we can adjust the opioid dose. We can adjust two ways. You can adjust up, you can also adjust down, okay, depending on the patient's pain level. So let's say if the pain level is rising, so what do? Do you titrate up or down?
Up.
Up. If the pain level is improving over past few days, do you titrate up or down?
Down.
Yeah, okay, so you get the idea. Now, this titration is based on the nurse's judgment. Okay, now when it comes to titrating up, of course, you need a doctor's order in order to titrate up. Let's talk about a ceiling effect. Okay, so let's go back to the opioids we talked about earlier. So there were two groups, right? We got the MU agonists and then we got agonist antagonist drugs. So the MU group, these opioids here, have no ceiling effect. What do you mean by ceiling? So look up, everybody. I'm sure everywhere you are, there's a ceiling above you, right? So what does the ceiling represent? If you look up on the ceiling, what does that represent? Can you go?
The highest level?
Like.
Okay, so that's like a limit, right? I mean, you can't go past the ceiling. Can you?
No.
No, not through there. You have to go upstairs or the elevator to go higher than that. So a ceiling is like a limit, correct? Yes?
Yes.
All right. So that's for the first group. The second group, does these drugs here, these opioids here, do have a analgesic ceiling. The first group do not have an analgesic ceiling. So let's go to the ceiling again. Okay. So as mentioned, the first group, which are the mu agonist opioids, have no analgesic ceiling, which means, do they have a dose limit?
No.
No. So the doses can be safely increased as long as the patient needs it. Again, we're not the ones increasing this, it's the physician. However, because we're the ones giving it, it may cause concern for us when we see large doses of opioids being prescribed, and then we worry, and then we end up not giving it. Okay, not understanding that these opioids do not have a ceiling effect. Okay, so it's important to understand this so that you're not underdosing or you're not undertreating a patient's pain. Although the dose may be limited by adverse effects, meaning if the patient now has severe constipation, okay, or let's say they're having over sedation, or let's say respiratory depression, of course, that will have to limit the dose. But the dose is not limited by the ceiling. It's just limited by the adverse effects. Do you understand this?
Yes.
All right. Okay. But the others, though, the nalbuphine, these here, buprenorphine and butorphanol, these have a ceiling effect. Okay, so they have a limit on the dose. The others do not. They have no analgesic ceiling. All right, so here are principles you can follow when using opioids. They're self-explanatory. Let me just point out a few things. Again, use multimodal analgesia. If you have non-opioids available, use them as well. Preemptive analgesic agents. This is what we call earlier by, we talked about earlier on around the clock dosing, okay, rather than PRN intervals. Consider diagnosis. So let's say the patient has kidney injury, AKI or CKD. So you know already, right, that this can cause drug toxicity. Okay, so consider the patient's condition when giving medications. Also consider the age. You may become impatient. Let's say this 80-year-old patient won't stop complaining of pain after you gave a dose already, and you forgot that their drug metabolism is slow, their drug excretion is slower. So you may become impatient and give them so many doses, and then next thing you know, the patient's already unconscious, okay, already in overdose, already in respiratory depression. So just be careful, okay, when using them. Use what you learn, right? Something about the transdermal earlier, the patches. Make sure you remove the old patches first before you put on a new one, because not all EHRs have that. Epic will usually ask you to remove the old one, but other EHRs do not. So sometimes you may see patients with 4 or 5 patches, okay, because the nurses just put one on and don't bother to look for the old patch, okay? All right. For adverse effects, yes, they are unpleasant, especially the constipation, but we can treat them, okay? So don't let the adverse effects discourage you from using opioids. And same goes for the patient. So encourage the patient to continue, because pain relief is important, but so is also managing the adverse effects. They just come with the territory. Okay, this is the last part for today and for the exam. Equinalgesia. What does this mean? Equal analgesia. So this is what I meant earlier by when we discharge a patient who's been on opioids during the hospital stay. Purpose again is to prevent withdrawal symptoms. So we ask them to fill the prescription and then follow the instructions on how to use it on the script or on the prescription bottle. This can be also used to just continue pain management at home, especially if the patient has chronic pain. But if it's, let's say, post-op and we're trying to wean off the patient from the opioids, then whatever the case is, it's important to note equinalgesia. Now, although the doctor is responsible for this, and sometimes the doctor will confirm with you because, again, they're not there 24/7, so they'll talk to you and ask, okay, how was the patient on this dose? And then they'll confirm, have you been giving, let's say, 10 milligrams of morphine? All right. And then you say, yes, yeah, he's been doing good on 10 milligrams. All right. It's important because now they have to prescribe the oral form, the oral preparation, which has the same equivalent with the parenteral dose. And how you do that is this table right here, 9-3. There is not a lot. There are only 3, I think, that are available both in IV and oral forms. Because some of them, like let's say fentanyl. Fentanyl has no oral form, only comes in IV and patches. Okay, so the oral things you see on the street are not legal. Okay, so the drug companies do not make oral fentanyl. That understood? So it's only available in patches and IV. Okay. So here, so I said only 3, correct? No, sorry, 4. There's oxymorphone. So they are morphine, hydromorphone. No, there are 3. Yeah, 3, sorry. And oxymorphone. So only 3 have both oral and parenteral route, at least on this table. So that's all you're memorizing for the exam. What are they again?
Morphine, hydromorphine, and
Hydromorphone.
hydromorphone, and
And
the last one on the chart, oxymorphone.
only 3. So morphine 30 PO is equivalent to 10 IV sub-Q IM. Hydromorphone 7.5 oral equal to 1.5 IV sub-Q. I mean, no, it's not given sub-Q. IV IM. And then oxymorphone 10 milligrams PO, 1 milligram parenteral. Okay, that's it.
Do we need to know for like the peak and stuff? Do you want us to know like?
No, that's okay.
Okay.
The last part, you discussed this in fundamentals, right? You know the difference between physical dependence, tolerance, and addiction? And this is not new.
Yeah. Yes.
You understand, right?
Yes, I understand.
Okay. So if I put, I describe the patient's behavior and then ask you to identify, you can answer that? Whether
No,
this
Professor.
physical dependence.
Professor, can you go over it, please?
Okay. Thank you, Ms. Carlo, for reading. What is physical dependence?
It's a normal response that occurs with repeated administration of the opioid with intensity and duration dependent upon the half-life of the medication and how long it has been used. It is manifested by the occurrence of withdrawal syndrome, withdrawal symptoms when the opioid is suddenly stopped or rapidly reduced, or an antagonist such as naloxone is given.
Okay, so long story short, the longer you use something, then the more your body likes it, and then your body, this is not the same as addiction. Okay, so addiction is different. So this one, your body just craves it, so that when you suddenly stop taking the opioid, it results in withdrawal symptoms. and we saw the withdrawal symptoms earlier, which is select all the apply question, but you didn't like it. But again, I wasn't asking. Okay. What is tolerance? How does it differ from physical dependence? Thank you for reading. Ms. Mira.
Tolerance is also a normal physiologic response that can occur with regular administration of an opioid and consists of a decrease in one or more effects of the opioid. For example, decreased analgesia, sedation, or respiratory depression. Although it may occur in conjunction with COD, it cannot be equated, but it's SUD. It may be treated with increases in dose to attain the previous effect.
Okay, so this simply means just like alcohol. So if you remember, if you drink, you remember the first drink you had, you got tipsy with your first shot, right? But then the more you drank alcohol subsequently, you know, a few weeks, months later, and then over the years, now you discover, oh, I'm drinking 12 shots of tequila now, and I'm still not tipsy. Okay, so that's basically tolerance. So your body developed tolerance with the substance, including opioids. So no difference between alcohol and opioids or any other drug or food for that matter. So meaning you're requiring more and more doses of the same substance to achieve your desired effect. Okay, so that's tolerance. This is not the same as SUD, although it is a component with substance use disorder or addiction, meaning every addicted individual has tolerance. Does that make sense?
Yes, it makes sense.
All right, so these two go together, meaning substance abuse disorder always has tolerance, but it's not the other way around. Someone who is tolerant may not necessarily have substance abuse disorder or addiction, if that makes sense. So what is addiction? Addiction is a treatable disorder. This is a real medical condition, and just like any other medical condition, it is treatable. It's classified under neurologic. Now, this is a combination of factors. This is just not caused by consumption of opioids. Okay, someone taking opioids, that's not the only reason for SUD or addiction. Okay, so this is a more complex than that. So it is again a legitimate psychological or neurologic disorder, and it can be treated. Okay, so this is not easily developed. So this one is a combination of not only psychological, physical factors, but emotional as well. Okay, so this is shaped by the patient's experiences right here. So influenced by genetics, psychosocial, and environmental factors. By environmental, we refer to the not only the physical environment, but also the psychological environment as well. Okay? The patient's family or living situations is what we mean by environmental factors. And we already talked about withdrawal, and I'm not testing pseudo addiction. Right? Any?
So you tested the 4 that's bolded: physical dependence, tolerance, SUD,
and withdrawal.
Withdrawal.
Withdrawal we already talked about earlier. So these are the result of sudden cessation of opioids. Any other questions?